Welcome to this GE Healthcare educational series on Surgical Pleth Index monitoring. This measurement is a part of the GE Healthcare Adequacy of Anesthesia concept. It relates to surgical stimulation causing sympathetic responses of the autonomic nervous system, how such responses are normally suppressed by analgesics, and how those responses can be objectively measured. SPI provides information of the responsiveness of adult patients to surgical stimulation and noxious stimulation during general anesthesia, and it helps the clinician to titrate the level of analgesic medication according to an individual patient need. In this first video, we will be covering the clinical importance of assessing the adequacy of analgesia. Let's get started. The stress response to surgery is an unconscious response to tissue injury and refers to autonomic, hormonal, and metabolic changes that follow injury or trauma. The activation of the sympathetic neural and autonomic humoral pathways causes changes in heart rate, blood pressure, and blood circulation. Elevated levels of catecholamines and other hormones mark a sustained stress response. Prolonged surgical stress may stimulate biochemical reactions throughout the body, which may lead to increased morbidity and delayed postoperative recovery. Sufficient suppression of the pain pathways, or antinociception, reduces stress responses during surgery. Stress-free anesthesia with measurement-based control of analgesia and hypnosis has been shown to improve postoperative outcomes. Patient-centric opioid administration is also important to avoid post-operative side effects. For example, opioid-induced respiratory depression or opioid-induced hyperalgesia. Traditionally, clinicians observe heart rate, blood pressure changes, patient movement, and muscle tension to subjectively assess adequacy of analgesia. Unfortunately, often those parameters fail to indicate nociceptive events because of their non-specificity. During surgery, the level of stimulation varies continuously. This requires a constant matching of the analgesic drug concentration to the location and intensity of surgical stimulation. Therefore, an objective measurement for the level of antinociception may be needed to reduce inter-individual variability and improve clinical specificity and sensitivity of the surgical stress measurement. The objective measure of nociceptive stress response is a function of both the level of stimulation and the drug effect, that is, the balance between nociception and antinociception. SPI has been developed to follow the slow changes of the antinociceptive drug effect, the intensity of surgical stimulation, and the response to sudden acute stimuli. If administration of analgesia is inadequate relative to the level of stimulation, the patient may show responses such as increased heart rate and peripheral vasoconstriction. SPI derives both of these components, increased heart rate and peripheral vasoconstriction, from the Pleth signal that is measured by a pulse oximeter. First, both the heart rate and the Pleth amplitude are normalized to decrease interpatient variability by applying a histogram transformation on the raw time series data. Then a linear combination of the normalized values is computed with the following formula, in which PPGA norm is the normalized Pleth pulse wave amplitude and HBI norm is the normalized heartbeat interval. Research showed that targeting surgical and analgetic responses to SPI level variation has led to trustful outcomes. A recommended target window to achieve adequate analgesia would be within the SPI range of 20 to 50. During the clinical validation of SPI, the following outcomes were demonstrated. SPI shows statistically significant responses to surgical stimulation, which is evaluated, for example, by comparing SPI values before and after incision and at known surgical noxious events. The performances of SPI have been evaluated at broad ranges of stimulation levels. SPI reflects the level of nociception and could help guide intraoperative analgesics titration. For example, static and dynamic values of SPI correlated to remifentanil concentration. Change in SPI was significantly dependent on remifentanil concentration. SPI changed significantly with increasing depth of analgesia after a bolus dose of fentanyl. SPI is significantly lowered by analgesic medication such as remifentanil. It is not affected by non-analgesic medication such as propofol. Titration of opioids with SPI was associated with a reduced endocrine stress response. Thank you for watching this video series on SPI monitoring. In the next video, we will talk about the demonstrated clinical benefits of SPI monitoring.